Good afternoon. Thank you for joining us for the Ask a Radiologist webinar series. Before we get started, I'm going to share some housekeeping items for today's webinar. Everyone on the call will remain muted for the duration of the webinar. At the end, we will open the floor for live Q&A. We encourage you to ask questions, and you can submit your questions at any time using the chat box feature in the Zoom platform. If you would like to ask your question live, simply click on the Raise Your Hand button and we will unmute you during the Q&A portion. For today's webinar about advanced breast screening options, we are joined by Dr. Parikh, Dr. Dimovski, and Dr. Hill. We also have your physician liaison, Travis Roseborough, on the phone. If you have any needs regarding patient education, referral forms, or other materials, Travis can stop by for a visit at your practice. Dr. Parikh is a board-certified radiologist who has been in practice with Charlotte Radiology for 10 years, providing subspecialty care in both breast and body imaging. He is a Charlotte native and a proud Tar Heel, completing his undergraduate studies, medical school, and residency at UNC Chapel Hill. Dr. Parikh completed his fellowship training in breast and body imaging at Cornell University. Dr. Dimovski is a board-certified breast imaging radiologist who has been in practice with Charlotte Radiology for over 10 years. Dr. Dimovski completed her diagnostic radiology residency at the University of Maryland at Baltimore, followed by her breast imaging fellowship at the University of Virginia. Dr. Hill is a board-certified breast imaging radiologist. She completed medical school at Florida State University and her residency and fellowship at Emory University in Atlanta, Georgia. Dr. Hill is a member of several societies such as American College of Radiology, Radiological Society of North America, and more. I will now pass it over to Dr. Hill to begin the presentation.
Thank you all for joining us. Today we're going to talk about advanced screening options for higher risk patients. So we have no disclosures. So we'll start with talking about the lifetime breast cancer risk for women. So average risk is less than 15%. We classify intermediate risk as 15 to 19%, and our high risk patients as 20% or greater lifetime risk of developing a breast cancer. So for our high risk populations, again, those patients who have greater than 20% lifetime risk of breast cancer, two important components are family history and then a history of chest or mantle radiation therapy. So as far as family history goes, if your patient has two or more first or second degree relatives with breast cancer, a first degree relative with premenopausal breast cancer, or male relatives with breast cancer, that can alert you that they may be considered high risk for developing breast cancer during their lifetime. And then, of course, our patients who have had chest or mantle radiation, their risk of, they become high risk approximately 8 years after the completion of their treatment. And there's specific numbers that can be correlated with this increased risk for the amount of radiation that they have received. So the family history will oftentimes, overlap with hereditary breast cancers. So out of the breast cancers that are diagnosed, about 5 to 10% of those have a hereditary component. The most common, of course, being BRCA1 and BRCA2, but there are many other genetic abnormalities that have been discovered to increase women's risk of breast cancer. And then, of course, this is an area where research is ongoing. We will see patients who have a very strong family history, but their genetics come back normal, which is why we still take that into consideration when we're considering someone's lifetime risk. Even if their genetics comes back normal, their family history is very important. But the BRCA1 and BRCA2 mutations is, the majority of hereditary breast and ovarian cancers. You can see their lifetime risk of breast cancer is very high, depending on the study, particularly for the BRCA1 mutation, which is 50 to 85%, and the BRCA2, about 45%. And unfortunately, these patients are also at risk of other types of cancers, and so may need additional screening exams outside of their breast screening. So again, the overlap with the family history, the risk factors for having a hereditary breast or ovarian cancer, personal and family history of cancer diagnosed in less than 50, so premenopausal, Ashkenazi Jewish ancestry, bilateral breast cancer, family member with male breast cancer, And then these, members of the family who develop ovarian, pancreatic, fallopian tube cancers, which can be seen with the BRCA mutations, and then multiple family members across several generations affected by any of these cancers. So for imaging our high-risk women, we start with a mammogram. Everyone gets an annual mammogram. Everyone's recommended to get an annual mammogram. So the benefits of mammography, it's been proven over and over again to reduce breast cancer mortality, depending on the study, anywhere by 20 to 40%. It's widely available, it's low cost, and almost all insurance companies cover screening mammography, which is great. Of course, there's limitations like everything in medicine. The sensitivity depends on breast density. The overall sensitivity for mammography is good, 70, 80%, but as you increase the breast density, that sensitivity decreases. And this is particularly important for our patients who are younger, as breast density tends to be higher in younger ages. DCIS, which is the earliest possible time we can find a breast cancer, can be mammographically occult unless it starts to calcify. And then higher risk women do tend to experience more aggressive cancers. And so even if they're getting their annual mammograms, the chance of developing a breast cancer and it becoming more sizable or metastasizing is increased in these patients, even if they're really good about getting their annual mammogram. So for the mammogram recommendation for high-risk women, we recommend starting at age 30. Women who have had radiation before they're 30 years old should begin at age 25 or 8 years after the radiation, whichever is later. And then women diagnosed with breast cancer or atypia at any point during their lives will begin screening mammogram from the time of the diagnosis. And then the other thing that is strongly recommended for high-risk women is MRI. The benefits of MRI is that it increases cancer detection rate, an additional 15 to 20 cancers per 1,000 women screened. It's more sensitive than mammography or ultrasound in the high-risk populations. And it's not limited by breast density. It's our only imaging modality that is not affected by the woman's density. So, but of course there's limitations. So for MRI, the recall and biopsy rates are higher for MRI than mammography, although similar PPV. It's definitely more expensive. There's inconsistent insurance coverage, even for our high-risk patients who we know need it. And then there's limited access to MRI just because of the expense of the equipment. It's not readily available like mammography is. And then there's, questionable concerns about the gadolinium. Of course, we know NSF is an entity in patients with renal failure, although very rare. And then the other thing about gadolinium is that we do know that some of it will deposit in the brain, skin, and bone in patients receiving MRI. Although, we've been doing MRI for decades and there's no known impact, but we do know that it can deposit, and certainly something to take into consideration. So for our group, so 2007 to 2017, so for that decade, we completed almost 6,000 MRIs as high-risk screening. The callback rate for MRI was about 11%, which is just a little more than for mammography. The PPV of biopsy is 28% malignant. And then another 18% of the biopsies demonstrated a high-risk lesion, and about half of the MRI biopsies were benign. And our cancer detection rate was about 23 per 1,000. So very effective for finding cancer in these high-risk women. And here's an example of MRI. She's 37, family history of premenopausal breast cancer, had a normal mammogram, but you can see this area of enhancement in the right breast here. And that was biopsy to show DCIS.
Hereditary and familial breast cancers comprise only 20 to 30% of all breast cancers. The majority of breast cancers are sporadic, occurring in women without significant risk factors, so women in the average and intermediate risk categories. Breast cancer screening guidelines recommend annual mammography for average and intermediate risk women. However, mammography, despite its technical advances, has well-established limitations, namely a decreased sensitivity for the detection of breast cancer in women with dense breasts. Breast density refers to the relative amount of radiodense epithelial and stromal tissue compared with radiolucent fatty tissue. BI-RADS, or the Breast Imaging Reporting and Data System, classifies mammographic density into 4 categories. A is fatty, B is minimally dense, C is moderately dense, and D is extremely dense. Many breast centers use an automated volumetric density calculation for objective and consistent classification. 50% of women have dense breasts, so those would be the C and D categories. Breast density is important for 2 main reasons. Number 1, it masks breast cancer. The dense fibroglandular tissue appears white on a mammogram and hides breast cancers, which are also white on a mammogram. This leads to higher rates of interval and advanced stage cancers in women with dense breasts. Secondly, mammographic breast density is an independent risk factor for breast cancer. It contains more stromal and epithelial cells from which breast cancers arise. Women with extremely dense breast tissue have a 5.3-fold increased relative risk of developing breast cancer in compared to women with fatty tissue. Increasing public awareness of the shortcomings of mammography has led to passage of breast density notification laws, which are now in effect in 38 states. Some states require women be told that supplemental screening should be considered. The current landscape of breast cancer screening has evolved from annual mammogram to annual mammogram plus supplemental screening. Abbreviated breast MRI is an optimal supplemental screening test for average and intermediate risk women with dense breasts. Given its shortened protocol, reduced scan time, and relatively low cost, it's a way to expand the use of MRI to benefit more women. Abbreviated breast MRI is not limited by breast density. It has a significantly higher cancer detection rate than 3D mammography and screening breast ultrasound, and it detects small, node-negative invasive cancers. The improved early detection of breast cancer is an important means to decrease breast cancer mortality in women with dense breasts. Abbreviated breast MRI picks up 15.5 to 18.1 additional cancers over digital mammography, or 13 to 17 additional cancers compared with 3D mammography. Charlotte Radiology participated in a clinical trial comparing abbreviated breast MRI to 3D mammography for detection of breast cancer in women with dense breasts. The results of this study were published in JAMA in 2020. This was a multi-institutional cross-sectional longitudinal study in which 1,444 women between the ages of 40 and 75 with dense breasts were screened with both a 3D mammogram and an abbreviated breast MRI performed within 24 hours at baseline and then again after a year. These exams were interpreted by 2 independent breast radiologists who were blinded to the results of the other modality. The study found that abbreviated breast MRI outperformed 3D mammography for detection of breast cancer. Abbreviated breast MRI had a cancer detection rate of 11.8 per 1,000 women and a sensitivity for detecting IDC and DCIS of 95.7%, much higher numbers compared to 3D mammography. Furthermore, there were no interval cancers in this study. This is a mammogram of a 55-year-old average risk woman with dense breasts. The mammogram was read as negative. The abbreviated breast MRI demonstrates a small invasive right breast cancer, which was hidden by the dense tissue on her mammogram.
Okay, so next we're going to talk about an additional modality called screening breast ultrasound. So this is a modality that should be considered in patients with average or intermediate risk with dense breast tissue, especially those patients who cannot undergo breast MRI. Next slide, please. So the benefits of screening breast ultrasound include that multiple studies have shown an increased cancer detection rate compared to mammography alone. A large multi-center trial called the Akron 6666 trial found a supplemental cancer detection rate of approximately 4.3 per 1,000 cases. Now, these cancers tend to be invasive, small, and node negative, approximately 1 centimeter in size or less. Other benefits of ultrasound include that it is widely available, it tends to be relatively cost-effective, no IV contrast is required, and it tends to be more comfortable for the patient compared to modalities such as MRI. Next slide, please. So some of the limitations of ultrasound include that there's an increase in false positive findings and a lower positive predictive value compared to mammography or MRI. Now, more recent studies have shown that this false positive rate and the positive predictive value metrics improve for each year that the patient is participating in a screening breast ultrasound program. Other limitations include that breast ultrasound is highly operator dependent. In our practice, we have dedicated mammography technologists with extensive ultrasound experience that perform these studies. And these exams are also reviewed by a diagnostic radiologist at the same time. So screening ultrasound can be time and labor intensive, typically requiring 45-minute to 1-hour time slots. Now, with the advent of DBT or 3D mammography, some of the benefit of screening breast ultrasound is perhaps lessened compared with just digital mammography, 2D mammography alone. Now, if your patient is already getting screening mammography plus MRI each year, there's no incremental benefit of ultrasound. Next slide, please. So I wanted to go over an article that talked about screening breast ultrasound and looking back at the last 10 years after breast density notification laws were put into place. So this looked at over 30 trials of screening breast ultrasound and found that the overall cancer detection rate still remains approximately 4 cancers detected per 1,000 studies performed in the era of 3D mammography. And as mentioned, positive predictive value improved and false positives decreased with each subsequent year. Also, they suggested that patient compliance may be higher compared to MRI. So I wanted to show some illustrative cases of patients that had negative screening mammograms and who had cancers detected only by screening ultrasound. So this is a 72-year-old patient who had a negative screening mammogram. So you can see her mammogram images on the left side of your screen. So this was read as a negative study. Can we go back one slide, please? And so on this, you can see the negative mammogram. And on the right side of your screen, you can see the ultrasound, the screening ultrasound, which picked up a 0.7 cm irregular solid spiculated mass. And this came back as invasive ductal carcinoma. Next slide, please. This is another patient. This is a 74-year-old patient who had a right lumpectomy for DCIS 10 years earlier. So you can see her mammogram there on the left side of your screen. You can see the post-lumpectomy changes. This mammogram was read as negative. The patient, fortunately, was in a screening ultrasound program and was found to have a new primary invasive carcinoma, 1 centimeter mass that you can see there on the ultrasound on the right side of your screen. at the right breast 4 o'clock position. Next slide, please. So one additional case I wanted to show from this article was this is a 50-year-old patient with extremely dense breast tissue. She had a screening mammogram that was res negative. And this was also a 3D mammogram. And this patient was participating in a screening breast ultrasound program. And the ultrasound demonstrates what you see on the right side of your screen, which is a 1.2 centimeter spiculated mass in the right breast 11 o'clock position. And this mass was 12 centimeters from the nipple, so it was located well beyond the edge of where the mammography would show that tissue. And so fortunately, this patient was part of the screening ultrasound program, and this cancer was detected. Next slide, please. So in summary, I wanted to go over our practice recommendations for imaging. So our breast cancer screening recommendations for average and intermediate risk patients. So just to review, so average risk meaning less than 15% lifetime risk, and intermediate risk meaning between 15 to 19%. So for these patients, we recommend an annual screening mammogram starting at age 40. And in terms of supplemental screening, abbreviated breast MRI is recommended for patients with dense breast tissue. Alternatively, if the patient cannot receive MRI, then screening breast ultrasound is also an option. Next slide. So in our high-risk patients, so this is 20% or greater lifetime risk, we recommend a screening mammogram annually starting at age 30. And also, in addition to that, a breast MRI starting between age 25 to 30 as well. Now, if they cannot receive a breast MRI, then screening breast ultrasound is another alternative. Next slide. So just to show this in an algorithm pictorial format. So again, annual screening mammogram still remains the gold standard for breast cancer screening. So we recommend that for all patients. Now, if the patient is high risk, then a conventional breast MRI is recommended on an annual basis. If the patient is not high risk, but they have dense breast tissue, then abbreviated breast MRI is recommended, or alternatively screening breast ultrasound. If the patient does not have dense breast tissue, then no additional imaging is required beyond their annual screening mammogram. So these are some of our references, and I wanted to thank you all for joining us today. We appreciate your time. If you have any questions at this time, I'd be happy to answer those.
Thank you, everyone. And thank you so much again for giving us this extremely informative presentation. We actually do have a few questions that have been rolling in, but just as a reminder, if you do have any questions, feel free to enter them into the chat box feature, or if you would like to speak freely and live on the phone, simply click on the raise your hand button and we'll unmute you so that way you can speak directly to our radiologist. So the first question is, for women with implants, is there a preferred modality?
So for women with implants, we still recommend an annual mammogram. And implants do, breast augmentation does limit mammography somewhat, but it's still considered the gold standard for an annual screening. And then depending on their breast density and their family history and their other, potential risk factors for being at high risk, that would come into play as far as whether they need supplemental screening. But just having implants in itself does not necessitate supplemental screening outside of just the annual mammogram.
Thank you. So the next question we have is, how consistent are automated breast density measurement methods, as they can be area-based or volumetric?
We're currently using a Volpara for a volumetric breast density calculation at our MMP location, and the calculations are accurate and consistent year to year, more so than the former method of just assigning a density based on visual assessment by a radiologist.
Excellent, thank you. Another question that has come in is, At any time, is there a reassessment of dense breast tissue as patients age to go back to mammogram?
Yes. So,
go ahead, Anup.
Yeah, so their breast tissue density is assessed each year when they have their mammogram. So it's something that's assessed at the time of each exam. And so, and again, as Dr. Dimovski mentioned, the volumetric density is also something that's automatically provided. So we take that into account as well. But yeah, their breast density is assessed each year at time of their mammogram.
Okay, thank you. All right, someone has raised their hand, so I'm going to go ahead and unmute them so that way they can go ahead and ask you their questions directly. Okay, you should be unmuted.
Hi, yes, this is Suneet Kaur. I'm one of the internists at Myers Park Internal Medicine. And actually, just to follow up to that question, so what I was getting at is that if a patient has dense breast tissue and is recommended for MRIs, at some point, is there a reassessment of that breast density so that we don't have to continue doing, routine breast MRIs in place of going back to mammography screening?
Yes, it's reassessed every year when she has a mammogram, and with age, the breast density does lessen or decrease. So at some point, she may age out of being dense and needing that supplemental MRI.
So, okay, I see. So each year, and it's determined whether that supplemental MRI would be needed by mammogram rather than just continually ordering breast MRIs year after year.
That is correct.
I got you. Okay, thank you.
All right, so we still have just a few minutes. We'll go ahead and wait to see if there are any other questions that come through at this time. If not, you are more than welcome to reach out to Dr. Hill, Dr. Dimovski, and Dr. Parikh directly using their Charlotte Radiology email addresses here listed on the screen. All right, well, I do not see any other questions coming through at this time. Thank you again so much to everyone. Oh, whoops, just kidding. We have one more that came through. It says, are risk models reliable is the question.
Right, so the risk model that's most commonly used and that we use is the Parikh for, assessing the lifetime risk of breast cancer. As with everything in medicine, these things are always evolving. The newest models, of course, take into account not only the family history, but also take into account breast density, which is great because we do know there's an increased relative risk as the density increases. So I believe that's the most commonly used one is the Parikh, but there are many other models which have, variable reliability, but I think the Parikh is the one that the vast majority of breast imagers use.
Okay, fantastic. Thank you. All right, well, no other questions have come in now. So as we reach the top of the hour, I'll go ahead and wrap up. Again, thank you so much to everyone on the line today who listened in and asked really great questions. And thank you, Dr. Hill, Dr. Dimovski, and Dr. Parikh for taking the time to give this extremely informative information. A follow-up email will be sent shortly with the recording of this webinar today, so that way you can go ahead and reference it at any point in time. So thank you again to everyone taking the time to tune in, and I hope you have a great afternoon.